Our next speaker is Dr. Paul Anderson. Paul, I think, really needs no introduction. He was the one who coined the term bone health optimization in the orthopedic clinic. He's a worldwide leader in getting orthopedic surgeons on board with bone health optimization and osteoporosis care, and he's going to talk about identifying osteoporosis in the orthopedic clinic. Paul?
Yeah, thank you, Neil. It's a pleasure to be here, and I welcome all the participants. Thank them for spending a evening with us to discuss these things. I'm going to move off of the physiology of bone and the different drugs and move into a little bit something a little bit more practical in the as orthopedic surgeons become more and more versed in the effects of bone quality and bone density on our outcomes, as well as much more involved in getting patients treated. And that's the topic is how do you identify osteoporosis in the ortho clinic? We know that osteoporosis is a silent disease until it isn't. And obviously, orthopedic surgeons are the ones who treat the majority of patients with fractures. So we do recognize a lot of that. But a lot of what I'm going to say is how does this apply to the elective patient? Here are my financial disclosures, which really have nothing to do with this talk. The objectives are to imply the definitions of osteoporosis that have expanded past BMD and maybe introduce kind of an orthopedic surgery definition of osteoporosis. And I want to encourage anybody working with orthopedic surgeons or surgeons themselves or fracture liaison service in ortho department to become bone detectives to look for osteoporosis. In particular, start utilizing many of the adjuncts to bone densitometry. So we know that the diagnosis using bone mineral density and DEXA has some problems, mainly that it's not sensitive to those who actually fracture. And also, people will have the same bone mineral density but fracture at radically different rates because of their age. And this has led to the development of a functional classification that includes not only bone mineral density but fracture history and fracture risk. And this clinical diagnosis of osteoporosis has been promoted to aid in treatment decisions. But what about the surgical patient? Are these the same as the patient we're trying to prevent osteoporosis? Well, this is an expansion over the clinical diagnosis. It's not just based on fracture risk, but it's also based on the risk of poor outcomes from the orthopedic or spine surgery. And this may include other things like the complexity of surgery, the adjuncts that we can measure, changes, and this may result in change of actually your treatment thresholds, and also a consideration of the biology on the fusion and bone healing to a greater degree than we worry about it for fracture prevention. And this slide is just to show what the difference is. If you take a 65-year-old female with osteoporosis, let's say her risk of a fracture within 2 years is 10%. I don't know if that number is correct, but it's probably close. But if you do a spine fusion on that same patient, that same age, her risk of fracture is still the same. However, now we're going to add on a 30 to 50% increased risk of osteoporotic related complications such as hardware failure, screw loosening, periprosthetic fracture, all of these things. And so these patients are at greater risk for complications that are outside of just fractures. So I'm basically saying that the orthopedic surgeon needs more from the bone than just fracture prediction. So, how do we get there? Well, this has become a bone detective, and the goal here is to identify those at risk, to screen to determine who needs further bone health assessment. And I'm not saying that every patient undergoing orthopedic surgery requires a DEXA scan or something. I'm saying they need a screening test to determine if they indeed do or would benefit from a DEXA. And this is based on history, physical exam, Various protocols have been created to identify those at-risk patients, primarily using risk factors. And then also, I'm going to talk a little bit about the surgical risk because different surgeries are just very risky if they fail at certain parts of the or certain areas of the bone. So the preoperative case finding is actually quite difficult in orthopedic offices. Surgeons are mostly unfamiliar with criteria and guidelines used to screen patients to determine if they need DEXA. It interferes with care flow pathways. It can lead to delay in surgery. And I'm just talking about the screening itself, not the pre-treatment. Most surgeons are uncomfortable with DEXA interpretation, and there is an unreasonable expectation that this is a primary care responsibility, or that maybe specialists should do this, of which we have too few. So the first question is, who needs further bone assessment? And I'm really talking about patients over the age of 50 or those with significant risk factors. And the ISCD about 5 years ago created positions on this topic. And basically, females over the age of 65, males over the age of 70, if they've had a history of a low energy fracture, or if they have high fracture risk, using the FRAX without BMD. Remember, patients theoretically have not had a DEXA scan at this point. And if answers to one of those is to any one of those questions is positive, then that patient would be a candidate for a DEXA scan. Now, there are other alternatives. Some spine surgeons will do a DEXA on everyone who's getting a spine fusion. Some surgeons will look at it and based on their perceptions, there's something called the Osteoporosis Self-Assessment Tool, or OST. And then we can use adjuncts like opportunistic CT, or also just factor in the surgical magnitude. You're doing revision surgeries or 12-level fusions. It's probably worthwhile getting a DEXA scan. Well, we've done a couple studies looking at the effectiveness of this screening protocol using the ISCD 4 questions, both retrospectively and prospectively. The results were very similar, but this one we looked at a broad-based group of orthopedic patients undergoing surgery, applied the clinical diagnosis of osteoporosis, and asked the question, did those screening questions identify patients who ultimately had osteoporosis? And the answer was absolutely. The screening test was positive 100% of the time, so it had sensitivity of 1, indicating that all the patients who subsequently had osteoporosis met one of those 4 criteria. The specificity in this retrospective study was 0.6, which is not bad. It meant 40% false positives, which is actually quite good for screening for osteoporosis. We also did a prospective study of just total knee patients, and the specificity in that one was not as good. It was 0.3. So the other thing is that the surgeons need to be educated about risk factors, as these act as red flags. They're well known, and basically they're the risk factors that are pretty much published in the FRAX tool. And we need to get orthopedic surgeons to pay attention to these. And when they're present, then the patient should be considered for further assessment. Well, the most important ones, and I would hope orthopedic surgeons could take a fracture history, is that patients after the age of 50, one should consider that they might be fragility in nature, and they certainly are important risk of future fracture with odds ratios of 2 to 5, depending on the timing. But more importantly for this discussion, they're associated with poor outcomes from orthopedic and spine surgery. This bar graph was a study of a large database of patients undergoing lumbar fusion and stratifying whether the patients had osteoporosis or not, and looked at the odds of complications. And you can see the complications ranged from 1.5 up to 6 to 7-fold for fracture-related complications if we did lumbar spine fusions in osteoporotic patients who were untreated. So clearly a fracture history prior to lumbar fusion. The same is also true for total hip and total knee arthroplasty. Now, some other hints we get on physical exam is we can go back to old school kind of technology here. There's this thing called a stadiometer, which measures height, and this should be done as many societies with universal agreement recommend that a recent height loss greater than 2 centimeters or a 4 centimeter height change from their maximum height are indications for DEXA, and there is a strong likelihood that the patient may have osteoporosis, fractures, or in the case of spine surgery, they certainly could have deformity, which also would make you shorter. So something simple as this people need to pay attention to it. So what about other alternatives than bone densitometry? These are adjuncts. Well, I think most of you are familiar with trabecular bone score. This is a textural analysis of the variation by pixel. And the idea is the more variation there is between pixel or voxel and voxel, the greater the bone is degraded. And it's a measure or an estimate of bone microarchitecture, and is also analogous considered as quality of bone. It is done with just software added to the DEXA scan. It can be done retrospectively, does not require further surgery. And the scores are given in terciles. Don't remember these numbers, but just look at the report. Should say whether it's degraded, partially degraded, or intact microarchitecture. And certainly patients who have degraded microarchitecture are at much higher risk for osteoporotic related complications. We have done a study where we did screw pullouts in the distal femur and compared trabecular bone score of the distal femur to bone mineral density to CT Hounsfield units. It found that the trabecular bone score was actually by far the most predictive of screw failure. This indicates that this providing information about microarchitecture may aid the surgeon in deciding how we're going to treat that patient. Another simple test is a vertebral fracture assessment, or VFA. This is done at the time of DEXA by lying the patient in a decubitus position, and then the patient is scanned up and down the spine. Usually we're seeing T4 to T5 to L4, and the idea is to look for occult fractures. And the ISCD's position on this is that if patients having orthopedic and particularly spine surgery, that a VFA should be added as a screening tool. Obviously, if I'm going to do a lumbar fusion at L3 to L5 for a condition, and the patient has a fracture at T10, that may cause me some apprehension and need further workup and treatment. Perhaps the most popular one gaining a lot of use, a lot of publications, is the use of CT scans. It seems like anybody who passes anywhere near a hospital these days gets a CT scan. And so these are available and can be used opportunistically to assess bone health. And the advantage is here we can measure things at a surgical site. And what we're measuring is something called the Hounsfield unit. And the Hounsfield unit is really the currency of the CAT scanner, and this is related to the X-ray attenuation of each voxel of tissue that is irradiated. Some of that energy that goes into the voxel is absorbed by the atoms, and some of it is diffracted. And how much is not allowed to pass directly through is what's called attenuation, and this is put into a coefficient, which is a unitless number. And we have extensive research done, a lot of it at the University of Wisconsin, on use of Hounsfield units. And you obtain this by placing a region of interest on your PAC system at the center of the body of L1 typically. And using that, there are well-established thresholds. I would say that if your Hounsfield units are less than 110, some people would say 100, you're very likely to have osteoporosis. If you're 110 to 150, you have low bone mass. Greater than 150 is normal bone. And if you have the first two, then that patient, I would recommend that patient have a DEXA scan. Surgeons would also use the value of those Hounsfield units to help us decide how we're going to treat that patient's surgery. So it does enter into surgical considerations, which I'm not going to talk about tonight. Well, again, let's go back to old school. What about just look at the radiographs? Do we get information from that? Well, many of you probably are not aware of this, but there's a uh, classification of the morphology of the proximal femur called the Door classification that strongly or moderately correlates to osteoporosis. And what we see in patients with osteoporosis is they get a thinning of the cortices in the proximal femur and also some remodeling so that the diameter actually increases. And that increases the area of moment of inertia. So it actually helps to resist fractures, even though the cortices are becoming thinner because the diameter is getting bigger. But this results in some morphologic differences of the femurs. And there's three classifications, door A, B, and C. Door A is a very narrow isthmus with thick cortices, whereas the door C has just thin cortical bones. It looks like a tube, a very thin walled tube, and a very capacious canal. And this is problematic because if we're going to put a prosthesis in there, we don't get any resistance because there's no bone in the proximal femur. And you can do it quantitatively as well. This is called the cortical index. But surgeons are using this to decide for cement arthroplasty. But I also recommend that this would be a good screening criteria. So if you have door B and C, the position statement by ISCD is to get a DEXA scan. Well, this is one of the hot topics, of course, is the use of artificial intelligence. And there's products out there, several of them now that have been FDA approved, where they can now look at plain X-rays and based on their learning models from patients with the same X-rays with known DEXA scans, give you a prediction of whether the patient has osteoporosis. This is one product we're testing here at the University of Wisconsin to see how it matches up against our other screening criteria. But I think this is going to be very valuable in the future where we can just look at the X-rays that we're obtaining for surgery anyway and tell us whether it's likely to have osteoporosis or not. This would not be used for treatment or monitoring, but mainly to identify those who need further diagnosis. Finally, I'll just mention surgical risk. How does this all play into this? Well, some of the higher risk surgeries are the multi-level fusions, and we may do 12-level fusions, put in 24 screws. Big operation. Also, if we're ending an operation at the level of the spinal cord, which would be above T12 and above, if something goes wrong there, such as a fracture or kyphosis, now we're entering the spinal cord into potential harm. And I would say one of my euphemisms is the spinal cord does not take a joke very well. And patients are with fractures after long fusions ending up paralyzed. Versus if it's in the lumbar spine, most of the cauda equina tolerates that better. Revision arthroplasty has about a 30% rate of periprosthetic fractures intraoperatively as well as postoperatively. Or if you're reconstructing after a low energy fracture, these of course are associated with higher complication rates. Or if you're doing revision surgery with osteoporotic related complications, I would suggest, now I don't have any data to back this up, that this patient are good candidates for bone health assessment and perhaps osteoanabolic treatment prior to surgery. So again, getting back to being a spine detective, we need to take all of these factors into consideration and eventually decide, hey, does this patient need more testing before we start surgery? And if the patient does meet thresholds for treatment, then that patient should get treated, hopefully prior to elective surgery, if at all possible. So in conclusions, osteoporosis is a difficult process to identify in the ortho clinic. I would suggest we use the expanded criteria of clinical diagnosis, but also maybe factor in surgical osteoporosis. You need to collect all available clues, and then try to find Mr. Body or identify osteoporosis. I don't know if any of you remember playing Clue, but the dead person in Clue was Mr. Body. So I thank everybody for your attention and look forward to some questions.
Thank you, Paul. I'll start. Would surgical osteoporosis have a different definition based on the procedure?
No, I think I would just categorize those into high risk and low risk or something like that. Not try to uh, stratify them too much.
So, Paul, I just want to thank you for being the person who spearheaded our attention to this incredibly important thing that I think was kind of previously ignored by us too. And I think now there's a lot more surgeons that are really in tune to that. I mean, I think this is clear in Wisconsin and throughout the United States, but it's really important, and you should be commended for the work you've done.
Yeah. Thank you. I would say most large spine groups are attempting some form of this. Um, and we have to congratulate them for enrolling this. And there's a lot of interest. I'm asked to speak all the time on this. So there is a big growing. I think the arthroplasty surgeons are not as buying into it as much as they're under pressure to do as many cases as they can and not to have road bumps into their pathway of getting more total joints in. So we're having some challenges getting that. But this is where the bone health doctors can help the surgeons try to develop a screening programs that can work in a busy orthopedic clinic. If you think about it, like some of my partners who do total joints might do 20, 25 cases a week.
Oh my goodness.
Um, and maybe to get 25 cases, they might see 50 patients a week. And so the question becomes, how much time do you have to engage in this screening process? I think it's something we have to solve. We just don't quite know how to do it as yet.
And I can see why the hospitals want those surgeons to do their 25 cases a week because it supports us all.
They are generally money makers, right?
Yeah.
I have a question. Is there any, so with the CT Hounsfield units, is there anything that can be done with an MRI? Sometimes I have an MRI, but not a CAT scan, and then insurance doesn't want to pay for the CAT scan.
Yeah, so there is something called opportunistic MRI. I didn't mention that. I didn't think I'd have time to go through that. This one is less sensitive than the CT Hansfeld units, and there's some issues with it. But the idea is that on a T1 weighted MRI, which is what's called fat sensitive, so it gives a much higher signal, which appears whiter when you look at it on the MRI if there's a lot of fat. So osteoporotic patients have a lot more fat in their bone marrow, and so they will have higher signal intensity. They also have less bone, and bone is dark on T1 weighted image, which also will drive up the signal intensity. This has to be normalized to the water, which is the spinal fluid, and that ratio and usually the ratio between the signal intensity from L1 to L4 to the CSF is greater than 3. Some people say 3.2. There's a correlation to likely having osteoporosis. However, there are many factors that go into this. The control settings on the MRI make a difference. The size of the patient makes a difference. Even some of the fat type of medical conditions, such as hyperlipidemia, obesity, alcoholism, type 2 diabetes, all will force more fat into the bone, and so it could falsely elevate it. We did a study across decades of life, and we found even with that ratio, like 20% of 20-year-olds had high ratios. So it's something that you can use in the absence of nothing else to help you screen. But I tend to go more towards the CT scan. But frankly, fracture history is amazingly sensitive.
Paul,
Yeah,
can
I
we do
think
that
the,
in the clinic ourselves, like we can do Hounsfield units? It sounds like
Yeah,
we're
absolutely.
okay.
Yep. It's a
yeah,
little technically more challenging.
Yeah.
so the contrary take on that is my take on what Paul just said is that MRI has potential, and in my opinion, it's just not ready for prime time yet. It's much more the vertebral bone quality score, and MRI is just much more complex than CT. And I've tried to use it, and I just don't ever know what to do with it. I think that people a lot smarter than me are going to have to figure out how to deal with the different settings in MR to allow us to get to where we're at with CT, whereas CT is totally ready for prime time.
You never order CTs uh, to get a Hounsfield unit. These are always, I mean,
It,
I've
it
only been just patients who have them for something else.
it would be rare for people to do that, but I have heard people tell me they will occasionally do that in the absence of being able to measure anything else.
Okay.
So if you have someone who has bilateral hips in, and maybe have some spine hardware in, um,
Yeah.
then they might use a CT scan. You can bill and code for this, for that. And
Thank
there
you.
are other things. You could do the biomechanical CT scan, which it shows some promise. It's difficult, costly, unreimbursed a lot of times. So we haven't used it very much. But I think the AI, Neil, with having artificial intelligence calculate the bone quality score from MRI and frankly from Hounsfield units from CT, could be really useful to us.
Excellent. Thank you so much, and thanks for the nice discussion.